Welcome to EM Rapid 2022. Myself, Dr. Naveen Mohan, Associate Professor of Emergency Medicine at Amrita Institute of Medical Sciences, Kochi. So let's discuss about pneumonia today. So what is pneumonia? Pneumonia is inflammation of the lung parenchyma, and it can result either from an infective cause such as bacteria, virus, fungus, or inflammation of the lung parenchyma can also result from non-infective causes such as radiation, kerosene poisoning. So for practical purposes, from an ER point of view, let us assume that infection of the lung parenchyma is pneumonia. The severity of pneumonia ranges from mild to life-threatening signs and symptoms. It can start off as an uncomplicated disease resolving with the usual antibiotics such as amoxicillin, or it can get complicated, leading to sepsis, septic shock, ARDS, and even death. So, moving on to the pathogenesis of community-acquired pneumonia. The major routes of acquisition of pneumonia are microaspiration, aerosol, and hematogenous route. And pneumonia usually happens in patients who have got impaired local defense mechanisms or impaired systemic resistance. And these pathogens, let it be bacteria, virus, or fungus, whatever, they come inside the alveoli, they enter the alveoli, undergoes uncontrolled replication. And at times what happens is these pathogens can enter the adjacent alveoli via the pores of Kohn or the canal of Lambert, like here. You can see this diagram. And there also it undergoes replication. So at the end of uncontrolled multiplication of pathogens, the resident alveolar macrophages inside the alveoli will start producing cytokines. And these cytokines will also enter the pulmonary circulation, and which may move to the systemic circulation and later on produce systemic signs and symptoms such as fever, tachycardia, hypotension. And also these neutrophils inside the pulmonary circulation will enter the alveoli via diapedesis, and an intense inflammatory response happens inside the alveoli. So the host immune response to microbial replication within the alveoli usually plays an important role in determining the disease severity. So at the end of the fight, all this pus will be accumulated inside the alveoli in a routine community-acquired pneumonia such as a streptococcus pneumonia related CAP. Okay. So this is also another diagram. The major immune cells which come into play in bacterial pneumonia are neutrophils and macrophages, and also the cytokines. And lymphocytes are involved in viral pneumonia. In viral pneumonia, the virus enters inside the cells and begin to multiply. And these cells are destroyed as the viruses burst through. And the lymphocytes sense and destroy the virus-infected cells. And type 2 pneumocytes grow to replace the damaged cells. This is the pathogenesis. So who is at risk for pneumonia? So I've already mentioned patients who have got impaired host defense mechanisms, impaired systemic resistance are at risk for pneumonia. So these are the patients who are at risk. Those who have got high aspiration risk, such as patients who are having some swallowing or esophageal motility disorders, stroke patients, patients who are having an NG tube, intubated patients, patients who had an episode of seizure, or patients at extremes of age, alcoholics, cancer patients, immunosuppressed patients, those with kidney failure, liver failure, valvular heart disease, or even those with chronic pulmonary disorders like COPD, chest wall disorders, bronchial obstruction, or patients who have undergone a bronchoscopy. So all these risk factors, all these are the risk factors for getting pneumonia. So moving on to the classification of pneumonia, it can be classified based on the site of acquisition and it can also be classified based on the etiology. Based on the site of acquisition, you can classify it as community-acquired pneumonia, nosocomial pneumonia, which encompasses both hospital-acquired pneumonia as well as ventilator-associated pneumonia, and healthcare-associated pneumonia. Healthcare-associated pneumonia is a retired term. So, CAP, nosocomial pneumonia, which comprises of both HAP and VAP. If you get the pneumonia from the community, then it's called community-acquired pneumonia. If you get the pneumonia from the hospital, it's called nosocomial pneumonia. And if you get, like, suppose the patient has gone to the hospital for some other reason, gets admitted in the hospital, and after 48 hours, he develops pneumonia. He develops a new patch in his lung. Then it's called hospital-acquired pneumonia. Whereas, if the patient has gone to the hospital for some other reason, gets intubated, and after 48 hours of intubation, patient develops a pneumonia. He develops a new patch in his lung. Then it's called a ventilator-associated pneumonia. The term HCAP is a retired term now. Previously, it was used to refer to pneumonia acquired from the healthcare facilities such as dialysis centers or nursing homes. But nowadays, it's not used. Another term which has come into role is VHAP, ventilated hospital acquired pneumonia. So suppose the patient developed hospital acquired pneumonia. Okay, that means pneumonia acquired after 48 hours of hospital admission, and he deteriorates. And he deteriorates to such an extent that patient had to be ventilated. Then it's called a ventilated hospital acquired pneumonia. So that is different from ventilator associated pneumonia. Okay, ventilator associated pneumonia, the pneumonia is acquired 48 hours after intubation. But in ventilated hospital acquired pneumonia, patient is already having a hospital acquired pneumonia, and the patient deteriorates and then gets ventilated. This is the most common pneumonia that we encounter in our hospital. Ventilated we have. So this is the classification by site of acquisition. If you go by the etiological classification, it can be classified as typical pneumonia caused by the usual organisms such as Streptococcus pneumonia, H. influenzae, Moraxella catarrhalis. And then comes atypical pneumonia caused by atypical organisms such as Legionella, Mycoplasma, Chlamydia, as we all know. And aspiration pneumonia, chemical pneumonitis, bacterial aspiration pneumonia. Aspiration pneumonia can occur because of entry of gastric or oropharyngeal fluids, which may contain bacteria into the lower airways. And chemical pneumonitis because of aspiration of substances such as acidic gastric fluid, which usually causes an intense inflammatory reaction in the lower airways. And that is independent of bacterial infection. That has to be borne in mind. That is independent of bacterial infection. If bacterial infection is there, you can straight away term it as bacterial aspiration pneumonia. Okay, I'll be dealing with these things later in the class. So moving on to the organisms based on the clinical setting. In community-acquired pneumonia, the usual organisms responsible are Streptococcus pneumonia, the most common, then H. influenza, Moraxella catarrhalis, Staphylococcus aureus, and also the atypical organisms such as Legionella, Mycoplasma, Chlamydia, Coxiella burnetii. And another major component is virus. Almost 30 to 50% of community-acquired pneumonia is caused by virus, such as RSV, parainfluenza virus, human metapneumovirus in children, influenza A and B in adults, adenovirus. Okay. And if you go to the healthcare setting, Staphylococcus aureus, methicillin-sensitive Staphylococcus aureus, methicillin-resistant Staphylococcus aureus, Pseudomonas aeruginosa, Streptococcus pneumonia. These are the organisms which cause healthcare-associated pneumonia in the healthcare setting. And hospital-acquired pneumonia, usually caused by more resistant organisms such as gram-negative rods, Enterobacteriaceae, Klebsiella, E. coli, and also the Pseudomonas species, and methicillin-resistant Staphylococcus aureus. So all these things will be much more resistant organisms. Aspiration pneumonia is caused by anaerobic oral flora, such as Fusobacterium, Bacteroides, Streptococcus, and it may be admixed with aerobic bacteria too, such as Streptococcus pneumonia, Staph aureus, such influenzae. And chronic pneumonia caused by nocardia, species, actinomyces, TB, atypical mycobacteria. Necrotizing pneumonia and lung abscess, usually caused by anaerobic bacteria, Staph aureus, Klebsiella, Streptococcus pyogenes. And in immunocompromised host, we usually get infection by cytomegalovirus, PCP, Pneumocystis jirovecii, invasive aspergillosis, invasive candidiasis, all these things. Okay. These pneumonia-causing organisms can be classified into typical and atypical bacteria and viruses. So this typical bacteria usually can be detected by gram stain and can be grown in agar, whereas atypical bacteria cannot be detected, visualized on gram stain, and usually cannot be cultured using traditional techniques. So also they have got atypical bacteria has got in some intrinsic resistance to beta-lactams group, and also the clinical features are a bit different from the typical bacteria. So these are the organisms which come under typical: strep pneumonia, H. influenzae, Moraxella, Staph aureus, MRSA, group A streptococci, GNB, Enterobacteriaceae, Pseudomonas, and atypical Legionella, Chlamydia, Mycoplasma, Coxiella. So these are the viruses: influenza, SARS-CoV-2, MERS, rhinovirus, parainfluenza, adeno, RSV, human metapneumovirus, human bocavirus. So we'll just go through some of these epidemiologic conditions or risk factors related to specific pathogens in community-acquired pneumonia. In alcoholics, Streptococcus pneumonia, oral anaerobes, Klebsiella pneumonia are more common. So these are important while taking history. So you'll have to understand whether the patient is an alcoholic, COPD, or patient has got a lung abscess, aspiration, whether patient has been exposed to bat or bird droppings, rabbits, patient is immunocompromised, or patient has traveled in a ship or traveled to any other places where certain specific kinds of organisms are more, or the patient is having some structural lung disease, or even patient is using injection drug use. All these things will have to be asked during history taking. So patients who are alcoholics, chances for getting Streptococcus pneumonia, Klebsiella pneumonia, Acinetobacter species, oral anaerobes are high. For those having COPD, H. influenza, Pseudomonas aeruginosa, Legionella species, strep pneumonia is high. For patients who are having aspiration risk, gram-negative enteric pathogens and oral anaerobes, infection is high. For those with lung abscess, community-acquired MRSA, oral anaerobes, fungal pneumonia, tuberculosis, atypical mycobacteria are high. For patients who are exposed to bat or bird droppings, Histoplasma capsulatum is high. Also, Chlamydia psittaci. Those exposed to rabbits, look for Francisella tularensis. For farm animals, Coxiella burnetii. In HIV infection, strep pneumonia, H. influenzae, and also these fungal infections such as PCP pneumonia, Cryptococcus infection, Aspergillus, pulmonary aspergillosis is high. So, and patients who have traveled in a cruise ship or exposed to some AC, look for Legionella species. You should suspect Legionella. And patients who are having a structural disease, look for Pseudomonas aeruginosa. And in the context of bioterrorism, anthrax, plague, tularemia, all these things will have to be considered. Okay. So moving on to the risk factors for community-acquired pneumonia caused by MRSA and Pseudomonas. So these are the strong risk factors for MRSA. If the patient is already has got a known MRSA colonization or a prior MRSA infection, or if in the sputum gram stain you detect gram-positive cocci in clusters on a good quality sputum gram stain, then you'll have to suspect MRSA. That's a strong risk factor to initiate treatment against MRSA. And in Pseudomonas, if the patient has got a known Pseudomonas colonization or a prior Pseudomonas infection, or you get gram-negative rods in sputum gram stain, or if the patient has got a history of hospitalization with the receipt of antibiotics in the last 3 months, then the patient is at risk for Pseudomonas infection also. So if these strong risk factors for MRSA and Pseudomonas are there, you'll have to anyway start treatment for you'll have to start antibiotic coverage for MRSA and Pseudomonas. And so these are the factors which should raise suspicion for infection of MRSA and Pseudomonas. So if the patient is that severely ill, then you will have to initiate antibiotics against MRSA and Pseudomonas if the patient falls in this category. So that is if the patient has got a recent hospitalization or receipt of IV antibiotics in the prior 3 months, recent influenza-like illness, necrotizing or cavitatory pneumonia, empyema, which is usually suggestive of a community-acquired MRSA, immunosuppression, and all these patients who are having these end-stage kidney disease, crowded living conditions, contact sports participation, because even this wrestling and all these things, wrestlers have got high chance of getting MRSA, and homosexual men. So all these things are the factors which should raise the suspicion for MRSA infection. Okay, and if the patient is that severely ill, the antibiotic should have coverage for MRSA also. And these are the factors that should raise suspicion for Pseudomonas infection: recent hospitalization or stay in a long-term care facility, recent antibiotic of any use, frequent COPD exacerbations requiring steroids, patients having structural lung diseases such as bronchiectasis, cystic fibrosis, immunosuppression. Okay, so if strong risk factors are there, treatment for antibiotic coverage for MRSA or Pseudomonas is mandatory. If there is only a slight suspicion of infection, you should initiate treatment if the patient is that severely ill. Okay. So moving on to the anatomic classification. It can be classified as bronchopneumonia, lobar pneumonia, or interstitial pneumonia. Bronchopneumonia is usually associated with a suppurative peribronchiolar inflammation, which can spread through the pores of cone, and it create a patchy consolidation of one or more secondary lobules of lung in response to bacterial pneumonia. So if you look at the X-ray, it will show multiple small nodular or reticulonodular opacities, which tend to be patchy or confluent, usually bilateral, asymmetric, involving the lung bases. Okay, but whereas in lobar pneumonia, it's usually associated with the homogeneous and fibrinosuppurative consolidation of one or more lobes of a lung. So if one lobe only is affected, then it's a lobar pneumonia. Whereas if you get a patchy consolidation of one or more secondary lobules of a lung, patchy, if it is a peribronchiolar involvement, then it's called bronchopneumonia. Whereas if in interstitial pneumonia, it involves the walls of the alveoli. The alveoli septa are widened and edematous and usually contain mononuclear inflammatory infiltrate of lymphocytes, macrophages, and plasma cells. Okay, so 3 types of pneumonia are there if you classify it anatomically: bronchopneumonia, lobar pneumonia, interstitial pneumonia. If one lobe is affected, lobar pneumonia. If it is like peribronchiolar inflammation, patchy consolidation, it's bronchopneumonia. Bronchopneumonia can progress to lobar pneumonia. And if it is the septa involvement, then it is termed as interstitial pneumonia. The usual causes here are in bronchopneumonia are Streptococcus pneumonia, Staph aureus, Klebsiella pneumonia, H. influenzae, Pseudomonas aeruginosa, E. coli, and lobar pneumonia caused by also caused by Klebsiella pneumonia, Legionella pneumonia, and H. influenza, and interstitial pneumonia caused by Mycoplasma, Pneumocystis carinii, virus, all these things. So regarding the stages of lobar, like stages of pneumonia, it usually it refers to stages of lobar pneumonia. The stages of pneumonia are congestion, red appetization, gray appetization, and resolution. So the stage of congestion includes hyperemia with alveolar edema and bacterial proliferation. Stage of red appetization includes hemorrhagic inflammatory alveolar exudate. Gray appetization includes fibrinopurulent inflammatory alveolar exudate. And stage of resolution involves the final stage of processing the residual exudation. So depending on which stage the patient is during presentation, the clinical signs and symptoms can vary. So in this diagram, the middle lobe is affected. So it is the lobar pneumonia. So this is the upper lobe, middle lobe. Posterior lobe is on the posterior aspect. Okay. And on the left hand side, you can see patchy consolidation, peribronchiolar area, that's called bronchopneumonia. Which is the interstitium. In the X-ray, if one lobe is affected, it's lobar pneumonia. It's usually unilateral. This is interstitial pneumonia, showing a ground glass appearance, usually bilateral and symmetrical. This is a bronchopneumonia with patchy diffuse bilateral disease, asymmetrical. So moving on to the clinical presentation, the pulmonary signs and symptoms, usually patient come to the ER with fever, dyspnea, cough, chest pain. Okay, and the systemic signs will be fever, fatigue, malaise, anorexia. The pulmonary signs include tachypnea, increased work of breathing, and in most of these consolidation, like lobar consolidation and all, trachea will be central. And at times, depending on what stage of pneumonia the patient is in, you'll get adventitious breath sounds, bronchial breath sounds, including rales, crackles, rhonchi, vocal resonance, fremitus, increased vocal resonance and fremitus, tactile fremitus, dullness to percussion, especially in lobar pneumonia. And the systemic signs will be tachycardia, leukocytosis, which is the most common, and even leukopenia. Then ESR, CRP may be elevated, procalcitonin may rise. Patient may have hypotension if the patient has developed sepsis, septic shock, and altered mental status, and other signs of organ dysfunction. So these are the clinical characteristics of the common bacterial pneumonias. Streptococcus pneumonia will have a sudden onset of fever with rigors, pleuritic chest pain, and cough will be productive. So if you examine the sputum, it will show a rust-colored sputum, and microscopy you can see a gram-positive encapsulated diplococci. And usually they produce a lobar pneumonia, lobar infiltrate. Occasionally it may be patchy or even pleural effusion may be seen. So sudden onset fever with productive cough, rust-colored gram-positive cocci, sputum, suspect streptococci. Staphylococcus aureus, it will be a gradual onset of fever, cough, dyspnea, and usually it happens after a viral illness. Okay, post-viral bacterial pneumonia, Staph aureus, and the sputum, if you look at it, it will be purulent, and gram-positive cocci will be found in clusters. And here you will have all these multilobar infiltrate empyema and lung abscess, which is characteristic of Staph aureus, empyema and lung abscess. Klebsiella pneumonia usually in alcoholics. It happens in alcoholics. You will have sudden onset, rigors, dyspnea, chest pain, and sputum will be bloody sputum, brown currant jelly sputum. And under the microscope, you'll get gram-negative encapsulated paired coccobacilli. And Klebsiella pneumonia usually involves the upper lobe infiltrate. Usually involves the upper lobes. And also you can, in the X-ray, you'll be able to see a bulging fissure sign. Abscess can also be there. In Pseudomonas aeruginosa, it's gram-positive coccobacilli and usually happens in hospitalized patients, debilitated, immunocompromised patients. And it will be patchy infiltrate with frequent abscess formation. H. influenzae, gram-negative bacteria, is usually seen in COPD patients and in elderly, and it will have a gradual onset of fever. And gram stain will show short, tiny gram-negative encapsulated coccobacilli. And Legionella pneumophila is commonly presents with fever, chills, and maybe also GI symptoms mostly, including abdominal pain, vomiting, diarrhea, and all these things. And it can also involve other organ systems such as the pancreas, causing pancreatitis, myocarditis, pyelonephritis, sinusitis. And also, one more point is Legionella pneumonia is usually seen in that air coolers and all. AC from the AC vents and all, you'll be able to find it. So that history has to be taken during the history taking. And X-ray will show multiple patchy, non-segmented infiltrates progressive to consolidation, occasional cavitation, and pleural effusion. So one major point you'll have to understand is Legionella pneumophila will have a dry cough. Okay, and the sputum, if you look at it, it will show no bacterial species as such. It will show few neutrophils. That's all. Also, in chlamydia, also the same thing. Chlamydia also, if you look at the sputum, it will show only few neutrophils, and organisms will not be visible. And chlamydia will have a gradual onset of fever, dry cough, and occasionally some sinus symptoms. Mycoplasma also same thing, a dry cough. So these are all atypical organisms: Legionella, Mycoplasma, chlamydia. On all these things, sputum will show few neutrophils and organisms will not be visible. Mycoplasma usually causes only interstitial pneumonia. Interstitial infiltrates the nodular pattern, and usually is picked up in CT. And Moraxella catarrhalis patient will have an indolent course of cough, fever, and more common in COPD patients. Sputum will show gram-negative diplococci. Anaerobic organisms to be noted is that putrid sputum, foul-smelling putrid sputum, especially in alcoholics. And the sputum will be purulent with multiple neutrophils and mixed organisms. I've already mentioned regarding Peptostreptococcus, Fusobacterium, and all those things. Okay, and the consolidation usually involves the dependent portion of the lung, and some abscess formation will also be there. So if you're moving on to the influenza pneumonia, the viral pneumonia, pneumonia is the most common complication of influenza. So the influenza pneumonia can be divided into primary influenza pneumonia, secondary bacterial pneumonia, mixed viral and bacterial pneumonias. Okay. So a primary influenza pneumonia should be suspected in patients with persistent symptoms and signs, including fever and dyspnea, after 3 to 5 days of acute influenza. Primary influenza pneumonia, whereas secondary bacterial pneumonia usually shows an initial improvement in the influenza symptoms and signs, followed by a relapse of fever and cough, and that is because of organisms which I've already mentioned: Staphylococcus, Streptococcus pneumonia, and so that is called secondary bacterial pneumonia. And at times you can get mixed viral and bacterial pneumonia, which has got features of gradual progression of symptoms or a transient improvement followed by worsening. So this is an X-ray of an influenza pneumonia, which progress over 1 week has progressed to this state. So 3 types of influenza pneumonia: primary influenza pneumonia, secondary bacterial pneumonia, and mixed viral and bacterial pneumonia. So moving on to the differential diagnosis of pneumonia. The respiratory illnesses that mimic CAP or can co-occur with CAP include acute COPD exacerbation, influenza or other respiratory viral infections, COVID-19, acute bronchitis, asthma exacerbations, And non-infectious illness that mimic CAP and present with pulmonary infiltrate and cough include CHF with pulmonary edema, pulmonary embolism, pulmonary hemorrhage, atelectasis, aspiration or chemical pneumonitis, drug reactions, lung cancer, collagen vascular diseases, interstitial lung diseases, bronchiectasis exacerbation, vasculitis, all these things. So how do you differentiate? So acute bronchitis is usually a precursor of bronchopneumonia. It involves primarily the large airways, the bronchi, but the alveoli or the pulmonary parenchyma are not involved. And usually in acute bronchitis is has got a prolonged history of cough following an upper respiratory infection. And the normally abnormal vital signs will be normal compared to pneumonia. That is about acute bronchitis, because here alveoli is not involved. In influenza, which is a precursor of pneumonia, has got a history of acute fever and cough, often accompanied by chills, rigors, myalgias, arthralgia, and influenza complication is primary influenza pneumonia or secondary pneumonia, which I've already mentioned, resulting in Staph aureus, secondary pneumonia caused by Staph aureus or even streptococci. And moving on to the upper respiratory infection, if you look at it, patient may have dyspnea and all, but the signs of consolidation will be absent on chest auscultation, and the presence of rhinorrhea or even pharyngitis will be present in upper respiratory infection. Coronavirus disease can range from asymptomatic infection to severe community-acquired pneumonia. And COPD exacerbation, we usually term a patient is having COPD exacerbation if the COPD symptoms go beyond the day-to-day variation. Typically, patient will have increase in the dyspnea, like normal. Otherwise, also patient will be dyspneic. But if the dyspnea increases when compared to the other normal routine days, and if the sputum volume and viscosity increases or the sputum purulence increases, then you term it as acute exacerbation of COPD. Acute asthma exacerbations is usually associated with cough, often worse at night, wheezing, and shortness of breath. Acute bronchiectasis exacerbations, patient will have a known history of bronchiectasis. Heart failure with pulmonary edema. It's another DD, but these are not related to the heart failure is related to the heart. These things are all related to the lungs. Then comes pulmonary embolism. Then comes lung cancer. Patient may present with a recent change in chronic smoker's cough, hemoptysis, signs of focal airway obstruction or physical examination, such as unilateral wheeze, decreased breath sounds, or even a patient may have also atelectasis. It's almost similar to pneumonia on chest X-ray. Then comes aspiration or chemical pneumonitis. Features are seen in the gravity-dependent areas of the lung, and will have a rapid improvement also. Then there's something called E-Valley. That's e-cigarette or vaping product use associated lung injury. Patient may have concurrent GI symptoms, and drug reactions leading to lung problem pathologies, nitrofurantoin, imidazole, daptomycin, methotrexate. All these things can cause lung involvement and pathology. Then comes interstitial lung disease, such as sarcoidosis, asbestosis, hypersensitivity, pneumonitis, rheumatoid arthritis, SLE, dermatomyositis. All these things can mimic a pneumonia. How to confirm a pneumonia? It's the routine investigations has to be sent as always, like total count, CRP, RFT, LFT, baseline, electrolytes, and all these things. But apart from that, the gold standard for pneumonia diagnosis is demonstration of chest X-ray infiltrate. We'll have to take both a PA view as well as a lateral view. Okay, and if the on top, like if we have got a definite patch in the lung, along with the supporting clinical and microbiological features, then you can safely diagnose it as pneumonia. And also regarding in the X-ray, we'll get to see air bronchogram as well as the Silhouette sign. The air bronchogram is defined as a pattern of air-filled bronchi on a background of airless lung. Okay, normally we are like the alveoli, the bronchi as such will not be visible till the end. But if the alveoli is filled with pus, what happens is this pus will appear as white in the lung field, and the black part, that is the air, will be seen more prominent. So that is called air bronchogram. And this is the Silhouette sign. Silhouette sign is basically the loss of lung and soft tissue interface. So this is the heart border. This is the heart, but you can't actually see the right hand side of the heart because of this opacity. So this lung soft tissue interface uh, differentiation is lost. So regarding X-rays, this is the right upper lobe, this is the right middle lobe. The right lower lobe is mostly posterior. The signs, if you get the signs posteriorly, it denotes that the patient is having right lower lobe involvement. And this is the left upper lobe, left lower lobe. Here is the lingula. On the right side, we have got 3 lobes. On the left side of the lung, we have got 2 lobes. So this is at a chest X-ray showing appearance in a lobar pneumonia. Middle lobe involvement. Here is upper lobe. This is the middle lobe. Lower lobe involvement usually will not be seen here in the this thing PA view. Here it's showing interstitial pneumonia caused by Legionella. This is a bronchopneumonia showing patchy consolidation here and there bilaterally around the bronchus, peribronchiolar involvement, suggestive of bronchopneumonia. Here it's a staphylococcal pneumonia with extensive infiltration and diffusion with some empyema is there. This is also a lobar pneumonia, left lower zone homogeneous opacity, pneumococcal pneumonia. Here it is a bulging fissure sign, chest radiograph suggestive of pneumococcal pneumonia. Here it's the mycoplasma pneumonia. Mycoplasma usually causes interstitial pneumonia. This shows bilateral interstitial infiltrates. Same thing, mycoplasma pneumonia. This interstitial infiltrates are more pronounced in if you take a CT. You can see bilateral ground glass opacities and some central lobular nodules here, and the stream bud appearance here also. This is the CMV pneumonia, cytomegalovirus pneumonia. It shows multifocal patchy pneumonia. This is the coronavirus pneumonia, which shows bilateral peripheral foci of ground glass appearance and peripheral foci of ground glass appearance and consolidation, but relatively the central part will be central region of the lung will be spared, usually in coronavirus. This one is an influenza pneumonia, which has progressed to one week later. It has progressed to this state. It shows bilateral extensive consolidation, and nodular opacities are all poorly defined. Okay. So moving on to the approach to community acquired pneumonia in the emergency department. As always, you should adhere to strict standard contact and droplet precautions as per the protocols. And community acquired pneumonia usually requires demonstration of an opacity on chest imaging. I've already mentioned these X-rays here. And the patient should have a clinically compatible syndrome also. So as always, you should take care of the airway breathing circulation as just like any other emergency case, ABCs. And the 2 major principles just to be borne in mind is you should define whether the patient is having severe pneumonia or non-severe pneumonia, and see where the patient has to be treated, if it is whether the patient has to be treated in the ICU, ward, or OP, and also see whether the risk factors for MRSA or Pseudomonas is there or not. So this table has been taken from UpToDate, and it is found to be useful in determining the appropriate site of treatment in adults who are suffering from community-acquired pneumonia. So the first question that has to be asked is whether the patient has got either septic shock, which requires vasopressor support, or whether the patient is having respiratory failure, which requires mechanical ventilation. If so, the patient can be admitted in ICU. If not, see if there are any practical concerns about outpatient management, such as inability to maintain oral intake, any history of substance abuse, mental illness, cognitive impairment, or whether there is any concern about living or social situations such as homelessness. In such cases, patient has to be admitted. If there are no practical concerns about outpatient management, see whether the patient's uh, oxygen saturation is less than 92% in room air, or if there is a considerable drop in the oxygen saturation level when compared to the patient's baseline saturation level. If there is considerable drop, then also the patient will have to be admitted and treated. If there is no drop, then you can apply the scoring system. There are two scoring systems that are widely used. One is the PSI scoring system, which is the preferred scoring system for pneumonia, community acquired pneumonia. The other one is Curve 65 scoring system. But compared to Curve 65, I think PSI scoring system is much more accurate and much more valid. But Curve 65 scoring system has got less number of parameters to be considered, and therefore calculation is much more easier for Curve 65 scoring system. For Curve 65, these are the parameters which come under Curve 65. C for confusion, U for urea, R for respiratory rate, B for systolic BP, 65 is the age. PSI scoring system I'll be mentioning later on. So depending on your preference, you can decide whether you want to go with PSI scoring system or the Curve 65 scoring system. If you're planning to go with the PSI scoring system, you have got 5 classes: class 1 or 2, class 3, class 4, class 5. Class 1 or 2 usually can be managed as an outpatient. Class 2 will have at times it can be managed as an outpatient, but sometimes a brief observational stay is also recommended. But anyway, class 4 or 5 will have to be admitted. But the decision is whether the patient has to be admitted in ward or ICU. So if the patient has got 3 or more of the following criteria, then he has to be admitted in ICU. The criteria includes altered mental status, hypotension requiring fluid support, temperature less than 36 degrees Celsius, respiratory rate more than 30, PaO2 by FiO2 less than 250, blood urea nitrogen more than 20, leukocyte count less than 4,000, platelet less than 1 lakh, multilobar infiltrates. If 3 or more of these criteria are there, you admit in ICU, where if it is not there, you can admit straight away in a general medical ward. Whereas if you are going with the Curve 65 scoring system, scores 0 can be managed as outpatient. Score 1 or 2 has to be admitted in the general medical ward. Score 3 to 5 has to be admitted either in ICU or medical ward. But the decision regarding whether to admit the patient in ICU depends on answering these crucial questions. And if 3 or more of these crucial criteria are there, then admit in ICU. Otherwise, admit in a medical ward. However, these scoring systems are not meant to override the clinician's judgment, overall judgment about the patient. These can be used as supplement to the clinician's existing clinical skills. So this chart has been taken from Tintinelli, which shows the pneumonia severity index. And these are the criteria which are generally considered while calculating the PSI scoring system. If any of these criteria is not there, then you can safely assign the patient as having class 1 risk. If any of these criteria is positive, then straight away go to step 2, which is basically collecting more lab and other data and assigning the points. And depending on the points, you can decide whether the patient falls under class 1, 2, 3, 4, or 5. So, for practical purposes, we usually classify community acquired pneumonia as mild, moderate, and severe. PSI class 1 or 2 or curve 65-0 falls under mild. 3 or 4 PSI falls under moderate. If it is PSI classes 4 or 5 or curve 65 score is 3 or more, then we usually classify it as severe community acquired pneumonia for practical purposes. So, for patients who are having mild community acquired pneumonia, these are the investigations that are generally sent. Apart from the routine investigations, the complete blood count, CRP, RFT, LFT, and all those things, the COVID-19 testing, especially during pandemic, will be done, and also influenza testing when incidence is high and results would change management. Otherwise, in a routine community acquired pneumonia which requires only ambulatory care, usually testing is not needed. But if the patient falls under the moderate cap criteria, patient anyway will have to be admitted in general medical ward. So apart from the routine investigations that are sent in the mild community acquired pneumonia and other investigations which I've already mentioned, like CBC, CRP, RFT, LFT, electrolytes and all, you'll have to send blood cultures also prior to administration of antibiotic. Because blood cultures helps us to find out whether there is any concurrent bacteremia or if there is any underlying endocarditis, which may usually go undetected. And because we usually follow pathogen directed therapy, because after 2 or 3 days we'll get the culture reports, and thereafter we'll be prescribing antibiotic against the pathogen which is detected in the microbiologic cultures. So it's a pathogen directed therapy. Then we'll have to send, if sputum is there, you'll have to do a sputum gram stain and culture. And also urine streptococcal antigen, because in India it's usually not sent, but it has been in Western countries, especially this has been mentioned in up to date, because the results of urine streptococcal antigen are less affected by antibiotic administration. So it is usually found to be beneficial if you're suspecting a streptococcal community acquired pneumonia. Whereas if the patient has got you're suspecting a Legionella, then you'll have to send sputum or bronchoalveolar lavage PCR, which is most preferable, the PCR, sputum or BAL PCR. But at times, because most of these Legionella strains will be picked up in PCR. But if it is not possible, then you can do a urine antigen, Legionella urine antigen. But the thing is, you'll be able to detect only the Legionella pneumophila serogroup 1. Okay. And apart from that, you'll have to also send sputum culture and sensitivity. Then comes the respiratory viral panel, which are usually sent during the respiratory virus season, but this is mostly reserved for patients who are suffering from the severe community acquired pneumonia. And apart from that, you'll have to send COVID-19 as always and the HIV screening. If the patient falls under the severe community acquired pneumonia category, that is PSI class 4 or 5, then apart from all these investigations, you'll have to send a respiratory viral panel, which is usually for severe cap, and there are institutions, like there can be variations among different institutions as to what comprises the various aspects of respiratory viral panel. Then comes, if the patient is already intubated or so, you can do a bronchoscopy, and the bronchoscopy specimens can be sent for gram staining, fungal stain, aerobic or fungal culture, and molecular testing when feasible. And if the immunity of the patient is that impaired, we can send a PCP stain or a PCR. And usually the rapid nasal PCR or the culture for MRSA is usually reserved for high-risk MRSA patients or those with severe disease or those who had a viral respiratory syndrome followed by a new deterioration. Okay, so first of all, you'll have to classify whether the patient is having mild, moderate, or severe, and depending on that, you should send these investigations. Now, a word regarding sputum collection. The sputum specimens should ideally be from a deep cough after rinsing the mouth, and it is obtained before administration of antibiotics and usually processed within 2 hours of collection. A good quality sputum sample is one with moderate or many polymorphonuclear leukocytes, but few or no squamous epithelial cells on gram stain. So this has to be borne in mind. After a deep cough, you rinse the patient's mouth and ask the patient to cough deeply and then obtain the sputum and process the sputum within 2 hours of collection. The decision regarding whether to send PCR for Mycoplasma, Chlamydia, and respiratory viruses is usually the respiratory physician's decision. And the culture results should be interpreted based on the following: the quantitation of growth, heavy, moderate, or light. Heavy and moderate is considered significant. Okay, and clinically, it has to be correlated, and correlation with gram strain should also be there, and the quality of the specimen. All these things has to be borne in mind while interpreting the culture results. Usually, these true pathogens are generally present in moderate or heavy amounts. These light amount is not considered significant. However, in cases if in sputum if you find Legionella, Bacillus anthracis, Mycobacterium tuberculosis, Chlamydia pneumonia, Chlamydia psittaci, regardless of the concentration, whether it's heavy, moderate, or light, it has to be taken. It has to be considered significant. One point to be borne in mind is when Streptococcus pneumonia or H. influenzae are the etiologic agent, false negative cultures may occur. And on the other hand, if Staph aureus and GNB are relatively rare pulmonary pathogens, so the failure to grow these organisms is a strong evidence against their presence. That means in your sputum, if you're finding Staph aureus or GNB, then it definitely means that Staph aureus or GNB is present in your sputum. Okay, that requires immediate antibiotic treatment. So this table shows the influenza diagnostic tests for respiratory specimens. The recommended tests include conventional molecular assays including RT-PCR and multiplex PCR, and rapid molecular assays, nucleic acid detection. And additional tests include rapid influenza diagnostic test, antigen detection, then direct and indirect immunofluorescence antigen detection. Then comes viral culture. The thing to be borne in mind is that the nasopharyngeal specimens collected with flocked swabs within 4 days of symptom onset, which is the preferred route. And else, if it is not possible, then you can combine both nasal and throat swab. Or in cases of in patients who are ventilated, you can use the ET aspirate or the BAL fluid. And this is basically transported in an antibiotic-containing transport fluid in ice and has to be refrigerated. A word regarding the multiplex assays to detect broad range of bacterial and viral pathogens. Most commonly available multiplex assays include BioFire Film Array Pneumonia Panel (PN panel) or Pneumonia Plus Panel (PN Plus panel). So both these things are basically US FDA cleared for use on lower respiratory tract specimens, and it usually detects chlamydia, pneumonia, mycoplasma, pneumonia, bordetella pertussis, influenza, RSV, parainfluenza, adenovirus, coronavirus, all these things. But the main thing is the true impact of these multiplex molecular assays is yet to be substantiated by data. It is usually not practiced in our hospital. So whatever said and done, the clinician may modify this approach based on the epidemiologic exposures, patients' risk factors, clinical features, and public health needs. And for patients with cavitary pneumonia, always test for tuberculosis, fungal pathogens, and nocardia. For immunocompromised patients, look for opportunistic pathogens such as Pneumocystis jirovecii, fungal pathogens, parasites, and cytomegalovirus. So these are the important pathogens which are critical to detect as it causes epidemiologic challenges. These include SARS-CoV-2, the community-acquired MRSA, Legionella species, influenza, and other respiratory viruses, zoonotic pathogens such as avian influenza A, H5N1, H7N9, hantavirus, Yersinia pestis, and also regarding the agents of bioterrorism, the Bacillus anthracis, inhalational anthrax, which causes inhalational anthrax, Yersinia pestis, which causes pneumonic plague, Francisella tularensis causing tularemia, Coxiella burnetii causing Q fever, influenza, hantavirus, ricin, and so on. So they all cause serious conditions that require treatment, and that differs from standard empiric treatment regimens, and also require special measures to prevent transmission from infected patients to staff and other patients. So these are the bioterrorism agents: anthrax, plague, tularemia, legionella, influenza, ricin. So there are some changes in the chest radiograph also. In anthrax, usually you'll get mediastinal widening, pleural effusions, and the onset to respiratory failure is usually 1 to 3 days. Whereas in plague, usually an X-ray will show bilateral infiltrates, and at times may have pleural effusion also, and the onset to respiratory failure is within 1 day. Tularemia, also bilateral infiltrates, but hilar adenopathy will be there. But these are all very rare incidents. Tularemia, like influenza, ricin, and all these are very rare. Now, how to differentiate viral cap from bacterial cap? So viruses are estimated to cause around 30 to 50% of all cap. So a single clinical feature or a radiographic finding or a test actually can't reliably distinguish between viral from bacterial pneumonia. However, in combination, the following findings are highly suggestive of viral pneumonia. A positive viral test, suppose a positive influenza PCR, low procalcitonin level, typically less than 0.25. Usually, we all know that more than 0.25 suggests of bacterial pneumonia. Or if there is any lack of microbiologic evidence of bacterial infection, suppose the blood and the sputum cultures are negative, or the urine or urine antigen test doesn't get you the bacteria, or if the radiologic findings are not that suggestive of bacterial infection, then all these things point towards a viral community-acquired pneumonia. So moving on to the treatment of community-acquired pneumonia. So this is the chart taken from UpToDate, and this shows the recommended antimicrobial therapy for specific pathogens causing CAP in adults. So the first one, the Streptococcus pneumonia, usually can be treated with penicillin, the normal penicillin, or even cefotaxime, ceftriaxone, fluoroquinolones. The H influenzae, if it is a non-beta lactamase producing H influenzae, it can be treated with a amoxicillin. Whereas if it is a beta lactamase producing H influenzae, you'll have to go ahead with second or third generation cephalosporin or amoxicillin clavulanate acid combination. If it is the mycoplasma pneumonia or chlamydophila pneumonia, go ahead with macrolide or a tetracycline, or even a fluoroquinolone as an alternative. For Legionella species, fluoroquinolone and azithromycin would suffice. Doxy can also be used as an alternative. For Chlamydophila psittaci, tetracycline or Coxiella burnetii tetracycline is enough. Macrolide can also cover that. For Francisella tularensis, doxycycline would suffice. Yersinia pestis, streptomycin, gentamicin. Bacillus anthracis, ciprofloxacin, levofloxacin. Enterobacteriaceae, all these third generation cephalosporins, carbapenems can be used. For Pseudomonas aeruginosa, the anti-pseudomonal beta-lactam plus a ciprofloxacin or levofloxacin or aminoglycoside can be used. For Burkholderia pseudomallei, which causes melioidosis. Usually carbapenem or ceftazidime are used. For Acinetobacter species, carbapenem is used. Staph aureus, if it is methicillin susceptible, it can be treated with the anti-staphylococcal penicillin. Alternatives include cefazolin, clindamycin. Whereas if it is a methicillin-resistant Staph aureus, go ahead with vancomycin or linezolid, depending on the patient's RFT. If it's Bordetella pertussis, go ahead with macrolide. For all these anaerobic pneumonia, which is usually resulting from aspiration, you can go ahead with beta-lactamase inhibitor combination and clindamycin. And for influenza virus, we'll deal with it later. Mycobacterium tuberculosis, isoniazid plus rifampicin plus ethambutol plus pyrazinamide. Histoplasmosis, itraconazole. Blastomycosis, itraconazole. So just go through this chart. Memorize what antibiotic goes with what organism. But these are not usually of relevance in the emergency department. Usually these are of relevance in the ICU, because once you get to know what exactly is causing the pneumonia, then you can tailor the antibiotic according to the resistance pattern. So this chart shows the recommended dosing of antiviral medications for the prophylaxis or treatment of seasonal influenza in adults. So oseltamivir, zanamivir, or baloxavir, all these things can be used. Oseltamivir is the commonly used drug in India. So the treatment dose includes 75 milligrams orally BD for 5 days. And for chemo prophylaxis, you can use 75 milligram OD. But still, a longer duration of therapy usually can be considered in very severely ill patients or in immunocompromised individuals, or particularly in those who have got continue to have viral RNA detected by PCR from a respiratory specimen. Now, moving on to the empiric antibiotic treatment for community-acquired pneumonia in the OP setting. So this chart has been taken from UpToDate. So under normal circumstances, the usual organisms that we target in a patient who is being treated as an OP case of community-acquired pneumonia are the Streptococcus pneumonia, as well as the atypical pathogens, such as Legionella, Chlamydia, Mycoplasma. And in that case, our antibiotic choice would be amoxicillin to address Streptococcus pneumonia, and also a macrolide, amoxicillin plus a macrolide or doxycycline, which is to target the atypical pathogens. Whereas if the patient has got any of these five factors, such as if the patient has got some major comorbidity or a recent antibiotic use, or if the patient has got age more than 65 years, chronic smoker, is dependent on alcohol, in such cases, the coverage has to be expanded, because in addition to the Streptococcus pneumonia and the atypical pathogens, you will have to address these beta-lactamase producing H. influenza, Moraxella catarrhalis, and some enterobacteriaceae such as E. coli, Klebsiella pneumonia, and MSSA. So in such cases, you will have to use amoxicillin clavulanic acid and not amoxicillin, plus the usual macrolide and doxycycline, which is basically to target these atypical pathogens. Suppose the patient has got allergy to penicillin, then you'll have to use a cephalosporin, usually a third generation cephalosporin, apart from the macrolide or doxycycline, which is basically to target atypical pathogens. If the patient has got some structural lung disease, then definitely you'll have to expand the coverage, because there are high chances of getting infection with enterobacteriaceae such as E. coli or Klebsiella. And in such cases, go ahead with respiratory fluoroquinolone. If structural lung disease is not there, you can even go ahead with a newer antibiotic, which is called the lefamulin, which comes under the fluoromutilin antibiotic class. So according to this chart, the major comorbidities which I mentioned are chronic pulmonary disease, chronic heart disease, liver disease, renal disease, cancer, diabetes, alcohol use disorder, and also immunosuppression, including asplenia. So just memorize this chart and see what all antibiotics come under each class and the dosage that is recommended. So this is basically the chart for outpatient antibiotic treatment of community acquired pneumonia. Moving on to the empiric antibiotic therapy for CAP in ward setting. Usually we start antibiotic within 4 hours of presentation if CAP is the working diagnosis. And the most frequently isolated pathogens in ward are Streptococcus pneumonia as always, and respiratory viruses such as influenza, parainfluenza, RSV, rhinovirus, COVID, and less often Mycoplasma pneumonia, H. influenza, and Legionella species. So any case of CAP, always see whether these risk factors are there or not. That is, if the patient has got some risk factors like known MRSA colonization, prior MRSA infection, detection of gram-positive cocaine clusters on a good quality sputum gram stain, or if the patient has got some known Pseudomonas colonization, prior Pseudomonas infection, detection of gram-negative routes on good quality sputum gram stain, or if the patient had a history of hospitalization with receipt of IV antibiotics in the prior 3 months. So all these things, these three things, are the strong risk factors which suggest treatment against, which suggest coverage for MRSA also, apart from the routine organisms which cause pneumonia. So these are the 4 factor questions that has to be addressed while taking history. If any of these 4 parameters are there, always suspect underlying Pseudomonas infection also and give adequate coverage for Pseudomonas also. So if strong risk factors are there, treatment is always required. So this part shows the factors that should raise suspicion for infection. So if these factors are there, then treatment is required, like coverage for MRSA and Pseudomonas is required if the patient is that severely ill. Okay, so if the patient has some recent hospitalization or an IV antibiotic use in the last 3 months, or necrotizing or cavitatory pneumonia, empyema, which is usually associated with community acquired MRSA, immunosuppression, end-stage kidney disease, injection drug use, contacts, sports participation, then the patient is, these are the factors which should raise suspicion for infection with MRSA. So these are the factors which should raise suspicion for infection with Pseudomonas. That includes recent hospitalization in long-term care facility, recent antibiotic use, frequent COPD exacerbations requiring glucocorticoids, other structural lung disease, and immunosuppression. So whenever you take the history, all these things will have to be asked. Then only you'll be able to reach a conclusion whether the patient has got any risk factor for MRSA or Pseudomonas. So this chart shows the empiric antibiotic selection of adults admitted to the ward. So basic organisms that we are going to address are the Staph aureus gram-negative bacilli, such as Klebsiella, in addition to the typical pathogens, which I've already mentioned, Strep pneumonia, H. influenza, Moraxella catarrhalis, atypical pathogens, all these things. So if there is no beta-lactam allergy, then the next question that has to be asked is whether the patient is at risk for MRSA or Pseudomonas. Okay, based on the questions, based on the previous slide. And if there is no risk for MRSA or Pseudomonas, you can select a combination therapy of anti-pneumococcal beta-lactam regimen or a respiratory fluoroquinolone regimen. Okay, so this is a beta-lactam regimen, anti-pneumococcal beta-lactam regimen. This is a fluoroquinolone based regimen. And if the, I've already mentioned, we'll have to cover atypical also. So if there is this, apart from the anti-pneumococcal coverage, we'll have to give an additional macrolide or a doxycycline to cover atypical. So, if there is no MRSA or Pseudomonas risk factor, you can safely give an anti-pneumococcal beta-lactam plus a macrolide or an anti-pneumococcal beta-lactam plus a doxycycline. The other option possible is fluoroquinolone-based regimen. The respiratory fluoroquinolone monotherapy can be given. This is the list of antimicrobial classes and the drugs which come under each class. You can go through this chart. If the patient has got an MRSA risk factor but no Pseudomonas risk factor, then you can safely go ahead with the anti-pneumococcal beta-lactam regimen or a respiratory fluoroquinolone, just like this. But the only difference is that apart from the anti-pneumococcal beta-lactam, you'll have to add an anti-MRSA agent such as vancomycin or linezolid as given here, depending on the patient's RFT and also the platelet count. And definitely a macrolide or a doxycycline has to be added for atypical coverage. The other possibility for a patient having MRSA risk factor is giving fluoroquinolone based regimen. And on top of respiratory fluoroquinolone, you can add a anti-MRSA agent, vanco or linezolid. Okay. Then comes those patients having Pseudomonas risk factor only. Then, and you'll have to give an anti-pseudomonal or anti-pneumococcal beta-lactam plus an anti-pseudomonal fluoroquinolone. Pseudomonas 2 coverage has to be given, both anti-pseudomonal beta-lactam plus anti-pseudomonal fluoroquinolone. The corresponding drugs are given in this chart. If both MRSA and Pseudomonas risk factors are present, then you'll have to give an anti-MRSA agent plus an anti-pseudomonal agent or an anti-pneumococcal beta-lactam plus an anti-pseudomonal fluoroquinolone. So for Pseudomonas, 2 coverages have to be given, anti-pseudomonal beta-lactam plus anti-pseudomonal fluoroquinolone. And for this MRSA, you can give an anti-MRSA agent. But if the patient has got some allergy to beta-lactams, still you can go through this slide. Respiratory fluoroquinolone monotherapy, if there is no MRSA or Pseudomonas risk factors there, can be given. If it is MRSA risk factors there, you can give a respiratory fluoroquinolone plus an anti-MRSA agent. If Pseudomonas risk factor is there, you can give levofloxacin fluoroquinolone plus astriona plus aminoglycoside. If both MRSA and Pseudomonas risk factors are there, you can give an anti-MRSA agent plus levoflox plus astriona plus an aminoglycoside. Okay. So please go through this chart, understand how it works, and administer drugs appropriately. So regarding influenza therapy, antiviral treatment is usually recommended as soon as possible for all persons with suspected or confirmed influenza requiring hospitalization or who have progressive, severe or complicated influenza infection, regardless of the previous health or vaccination status. This is about the treatment of community-acquired pneumonia in the ward. Now moving on to the empiric antibiotic therapy for CAP in the ICU setting. Usually we'll have to start antibiotic within the first 1 hour of presentation if the patient is in septic shock. And the most frequently isolated pathogens in ICU are strep pneumonia, Legionella, GNB, Staph aureus, influenza, and community-acquired MRSA, which causes necrotizing pneumonia. So in this chart, it shows the empiric antibiotic selection in ICU. So similar to the previous chart, here also the question is whether the patient has got a beta-lactam allergy. If allergy is not there, then questions are aimed to find out whether the patient has got a risk factor for MRSA or Pseudomonas. If there is no risk factor for MRSA or Pseudomonas, there are 2 options. You can either go ahead with a respiratory fluoroquinolone regimen or a macrolide containing regimen. In the respiratory fluoroquinolone containing regimen, you can use a anti-pneumococcal beta-lactam plus a respiratory fluoroquinolone in an ICU setting. If you're going ahead with the macrolide containing regimen, you can use an anti-pneumococcal beta-lactam plus a macrolide. Okay. Whereas if the risk factor for MRSA is present, then also you'll be going similarly, like in macrolide containing regimen or fluoroquinolone containing regimen. Only thing is that you'll be adding one anti-MRSA agent like vancomycin or linezolid. Same thing, not much of a difference. Okay. And if the patient has got a pseudomonas risk factor only, then you'll have to give two coverages: anti-pseudomonal pneumococcal or anti-pneumococcal beta-lactam plus an anti-pseudomonal fluoroquinolone. If both MRSA and pseudomonas risk factors are present, give an additional anti-MRSA coverage also. But if the patient has got some beta-lactam allergy, then your options are, if there is no MRSA or pseudomonas risk factor, you can use a respiratory fluoroquinolone plus astriona. If MRSA risk factor is only present and no pseudomonas risk factor, give an anti-MRSA agent along with this. If pseudomonas risk factor is only there, we'll have to give levoflox plus astrionam plus an aminoglycoside. On the other hand, if both risk factors, MRSA and pseudomonas risk factors are there, give levoflox, astrionam, aminoglycoside plus an anti-MRSA agent. So just like influenza therapy I've already mentioned, just like in ward, you will have to start antiviral treatment as soon as possible for all persons requiring hospitalization who have got severe or complicated influenza infection, regardless of vaccination status. So just go through this diagram very well, understand how it's working. Okay. Regarding the use of corticosteroids in CAP, it is controversial. But usually it's given in indications include septic shock, that is refractory to fluid resuscitation and vasopressor administration, or in respiratory failure with the FiO2 requirement more than 50%, plus one or more of the following clinical features such as metabolic acidosis with arterial pH less than 7.3, lactate more than 4, or a CRP more than 150. So you should always avoid glucocorticoids in patients with CAP known to be caused by a viral pathogen such as influenza or a fungal pathogen such as Aspergillus. This is important. If at all you are giving glucocorticoids, the dose is methylprednisolone 0.5 mg per kg IV every 12th hourly and treat for a total of 5 days. This is the recommendation. A word regarding procalcitonin in pneumonia. Procalcitonin is not well studied in immunocompromised patients, trauma or surgery patients, pregnant patients, those with cystic fibrosis, and those with CKD. Okay, so those with complex comorbidities, this algorithm may not be useful. And usually, procalcitonin level is obtained every 1 to 2 days, basically to differentiate between the viral and the bacterial causes of community-acquired pneumonia. Usually in bacterial community-acquired pneumonia, procalcitonin, if it is being treated properly, procalcitonin will progressively decline. In viral, usually procalcitonin level is less than 0.25 nanogram per ml. But at times what happens is both bacterial and viral pneumonia can occur at the same time. And basically the procalcitonin is usually used for decision regarding antibiotic discontinuation. Based on the fall in procalcitonin, you can decide whether to discontinue the antibiotic or not. So once you have started your empiric antibiotic therapy, you should reassess the patient after 48 to 72 hours. So the patient can either improve or deteriorate or can remain stable. If the patient is improving in the sense there should be subjective improvement as well as objective improvement. Subjective improvement in terms of decrease in cough, sputum production, dyspnea, and chest pain, and objective resolution of fever, normalization of heart rate, respiratory rate, oxygenation, total counts. Okay, so if the patient is improving, see Answer this question. Does CAP remain the most likely diagnosis? If still remains the most likely diagnosis, see whether a microbiologic diagnosis has been made or not. If it has been made, then you should consider transition to oral antibiotics and tailor the regimen to target the specific pathogen. And duration of treatment varies by pathogen, and usually a 5-day course is often sufficient. Whereas if CAP does not remain the most likely diagnosis, then you should broaden your differential diagnosis and consider discontinuing antibiotics. If the patient remains stable, then you should continue your antibiotic treatment if CAP remains the most likely diagnosis. And you should be monitoring closely over the next 72 hours and then reassess. But if the patient is deteriorating, see if there is rapidly worsening respiratory distress, or if there are any signs of sepsis. If so, then you should broaden the empiric antibiotic regimen immediately, and we should provide adequate respiratory and support and ICU care, expand the diagnostic evaluation, and also evaluate for complications such as bacteremia, empyema, and other non-infectious causes or contributors to the patient's syndrome. Or else, you should broaden the differential diagnosis and the diagnostic evaluation, obtain repeat chest imaging to assess for progression of disease and complications, and also to consider alternate diagnosis. So, most often, this evaluation happens inside the ICU and not the emergency department. So, if you have got an attached ER ICU, probably you should be handling all these areas. What in case of a non-resolving community-acquired pneumonia? Usually, a delayed clinical response usually happens in some patients, particularly those with multiple co-mouths. And usually, around 8 to 9 days treatment may be necessary in such cases with patients with multiple co-mouths. Whereas in case of loculated infection, usually diagnosed after you do a CT, then you should consider the possibility of lung abscess, empyema, or some other closed space infections, and that may require drainage or prolonged antibiotic treatment. If there is an bronchial obstruction, consider the possibility of a tumor. Okay, maybe like patient is already having a tumor, on top of that he's having a pneumonia, and that is why it's not getting resolved. And these are the pathogens that can cause subacute or chronic community-acquired pneumonia, such as Mycobacterium tuberculosis, non-tuberculous mycobacteria, fungi, or less common bacteria such as Nocardia actinomyces. Or the other possibility for non-resolving CAP would be an incorrect initial diagnosis. In such cases, always consider the possibility of a malignancy or an inflammatory lung disease. So, moving on to the duration of antibiotics for community-acquired pneumonia in patients. So, for patients receiving IV or oral antibiotics for CAP, see if the patient is having MRSA or not, methicillin-resistant Staph aureus pneumonia or not. If it is MRSA, the treatment duration is based on the clinical response. Minimum of 7 days antibiotic treatment is advised if early clinical response is there and no complications. But if concurrent bacteremia is there, you will have to treat for a minimum of 14 days. And for those patients with immunocompromised status and with metastatic complications, even longer courses, more than 4 weeks, are advised. If the patient is not having MRSA, then see whether any of the following applies. Whether the initial treatment is not active against subsequent identified pathogen, if there is any extrapulmonary infection, if there is any documented Pseudomonas aeruginosa or Staph aureus Legionella species or an uncommon bacterial species present, or if there is any necrotizing pneumonia, empyema, or lung abscess. If so, you will have to give individualized duration of therapy based on the clinical response to treatment and patient co-mouths. If not, see whether the patient is afebrile for around 48 to 72 hours if O2 is not required, or if the hemodynamic status is improving, heart rate more than less than 100. In that case, you'll have to discontinue the antibiotics after 5 to 7 days. If the patient is deteriorating, then you'll have to continue the antibiotics until the patient is clinically stable. And at the end of 7 days, you'll have to again re-evaluate the patient and do the needful. So this particular slide shows the selection of COVID-19 specific therapy in adults who have severe disease requiring oxygen supplementation. And depending on the level of oxygen or ventilatory support, you can decide whether to give dexamethasone, remdesivir, tocilizumab, etc. So just go through this slide. This is not of much importance in the emergency department. Usually, this is of relevance in the COVID ICU. This chart has been taken from up to date. Next, we have the other important aspect of pneumonia, that is the nosocomial pneumonia, which encompasses the hospital-acquired pneumonia, ventilator-associated pneumonia, ventilator hospital-acquired pneumonia. The 2016 IDSA guidelines for the management of HAP and VAP recommend a clinical diagnosis based upon a new lung infiltrate, plus a clinical evidence that the infiltrate is of infectious origin, which includes the new onset of fever, purulent sputum, leukocytosis, and a decline in oxygenation. The common organisms which cause nosocomial pneumonia are the aerobic gram-negative bacilli and the gram-positive cocci. Under the aerobic gram-negative bacilli comes E. coli, Klebsiella pneumonia, Enterobacter species, Pseudomonas aeruginosa, Acinetobacter species. Whereas under the gram-positive cocci, we have the methicillin-resistant Staph aureus, Streptococcus species, and also the atypical Legionella, usually in patients, hospital which have got water contamination, usually from the ACs and all. So what are the risk factors for hospital-acquired pneumonia? Usually, you should understand these things. This chart is also taken from up to date. So the risk factors for increased mortalities: ventilatory support for HAP, septic shock, risk factor for MDR pseudomonas and other gram-negative bacilli and MRSA are IV antibiotic treatment within the past 90 days. Risk factors for MDR pseudomonas and other gram-negative bacilli are structural lung disease, including bronchiectasis or cystic fibrosis, a respiratory specimen gram stain with numerous and predominant gram-negative bacilli, and a colonization or prior isolation of MDR pseudomonas or other gram-negative bacilli. Whereas the risk factors for MRSA includes treatment in a unit in which more than 20% of Staph aureus isolates are methicillin resistant, and treatment in a unit in which the prevalence of MRSA is not known, and colonization with or prior isolation of MRSA. So, the HAP usually happens because of microaspiration of organisms that have colonized the oropharyngeal tract. Okay, and the treatment of HAP should be based on the hospital antibiogram usually, and the MDR risk factors. So every hospital is supposed to maintain a hospital antibiogram based on which we can will be able to predict what might be the causative organism. So the empiric therapy for HAP and VAP should include agents with activity against Staph aureus, Pseudomonas aeruginosa, and other gram-negative bacilli. This one has to be borne in mind. So this slide shows the empiric treatment of HAP, not VAP, in patients with normal renal function. Okay. So if the patient has got risk factor for MRSA, then you will have to add either vancomycin or linezolid along with either piptas, cefepime, ceftazidime, levofloxacin, aztreonam. But if the patient has got no risk factor for MRSA, either piptas, cefepime, or levofloxacin will suffice. If the patient has got risk factors for MDR pseudomonas or other gram-negative bacilli as listed here, please recall the previous slide. If the patient has got risk factors for MDR pseudomonas and other gram-negative bacilli, Then it can be treated with piperazoline, tazobactam, cefepime, ceftazidime, meropenem, aztreonam, plus one of the following: tobramycin, amikacin, levofloxacin, ciprofloxacin, aztreonam. On top of this, if the patient has got some MRSA risk factor, you will have to add vancomycin or linezolid. If the patient has got a risk factor for MDR pseudomonas, other gram-negative bacilli and MRSA, then straight away you'll have to go here, add one among these: piptaz, cefepime, ceftazidime, imipenem, meropenem, aztreonam, plus amikacin, gentamicin, tobramycin, plus one of the following: vancomycin or linezolid. And if the patient has got risk factor for increased mortality also, the same thing. 3 antibiotics will have to be considered in case of hospital-acquired pneumonia, which is not ventilator-associated pneumonia. So moving on to the ventilator-associated pneumonia, the treatment of VAP should be based on hospital ICU antibiogram and the MDR risk factors. And the empiric therapy of HAP and VAP should include agents with activity against Staph aureus, Pseudomonas aeruginosa, and other GNB. So these things have to be understood. The risk factors for multi-drug resistant ventilator associated pneumonia, risk factor for MDR pathogens. These are the risk factors. IV antibiotic use within the previous 90 days, septic shock at the time of VAP, ARDS preceding VAP, more than 5 days of hospitalization prior to occurrence of VAP, acute renal replacement therapy prior to VAP onset. So these are the risk factors for MDR pseudomonas and other GNB. Treatment in ICU with more than 10% of gram-negative isolates which are resistant to an agent being considered for monotherapy. Treatment in ICU in which local antimicrobial susceptibility rates are not known. And colonization or prior isolation of MDR pseudomonas or other GNB. So these are the risk factors for MRSA. Treatment in a unit which more than 10 to 20% of Staph aureus isolates are methicillin resistant. Treatment in a unit in which the prevalence of MRSA is not known, or colonization with or prior isolation of MRSA. So this chart has to be understood before moving into treatment of a ventilator-associated pneumonia. These are usually VAP and all is managed in the ICU and not in the emergency setting. So according to this table, if there is no risk factor for MRSA, these are the risk factors for MRSA, then you'll have to give either piptaz or cefepime or levofloxacin. If there is a risk factor for MRSA, along with these things, you'll have to add an anti-MRSA coverage either with linezolid or vancomycin. If there is a risk factor for MDR pseudomonas and other GNB, then you'll have to treat with piptaz, cefepime, either piptaz or cefepime or imipenem or meropenem plus one of the following: amikacin, gentamicin, or tobramycin, levofloxacin. And that has to be tailored depending on the patient's underlying clinical conditions and clinical status. And if the patient has got needs MRSA coverage also, with the patient treatment was in a unit in which the prevalence of MRSA is not known at all, then you'll have to add vancomycin or linezolid also. And if the patient has got risk factors for MDR pathogens, these are the risk factors, then definitely 3 antibiotics have to be chosen: piptaz or cefepime or ceftazidime or imipenem or meropenem plus amikacin or tobramycin or gentamicin or aztreonam plus vanco or linezolid. This is about hospital ventilator associated pneumonia. So moving on to the differential diagnosis of pulmonary infections in the immunocompromised patient. That's altogether a different entity. Under bacteria, these are the common organisms which affect the immunocompromised patient: strep pneumonia, H. influenza, mycoplasma, legionella, chlamydia, and others. Also the fungi, which is of very importance in especially in HIV patients and all. Pneumocystis jirovecii causing PCP pneumonia, Aspergillus species, Aspergillus fumigatus causing invasive pulmonary aspergillosis, Cryptococcus neoformans causing cryptococcal lung infection, Candida mucormycosis. Also, under viral, we have got this cytomegalovirus, herpes simplex, and varicella zoster viruses, which causes primary varicella pneumonia, and also the community-acquired respiratory viruses such as influenza, parainfluenza, RSV, COVID-19, and also a word regarding parasites, Toxoplasma gondii and Strongyloids stercoralis. So whenever we encounter a HIV patient, usually we look for the CD4 count. That's depending on the CD4 count, the infections can vary. If the CD4 count of an HIV patient is more than 800 cells per millimeter cube, then bacterial infection is most likely, which encompasses strep pneumonia, H. influenzae, Staph aureus, group B Streptococcus malaria, Klebsiella pneumonia, and so on, Legionella, and so on. But if the CD4 count is between 250 to 500, then look for causes like Mycobacterium tuberculosis, Cryptococcus neoformans, Histoplasma capsulatum. But if the CD4 count is less than 200, and if the patient has got a prolonged corticosteroid use and also lymphopenia, then we should consider the possibility of a pneumocystis pneumonia. So these are the common radiographic appearances of pulmonary disorders in HIV patients. If you see a consolidation, usually it is by a bacteria. And usually the etiology will, within 24 hours, you'll see a consolidation, usually the bacteria. But if you see a diffuse interstitial infiltrate, it's most probably because of pneumocystis jirovecii. Or it can also be because of CMV, influenza. And H. influenza bacteria is also found to have found to produce similar radiographic appearances, and also ARDS. And nodular infiltrate is characteristic of bacteria. Pleural effusion, also bacteria, tuberculosis, empyema. Pneumothorax is very often seen in pneumocystis jirovecii. So PCP pneumonia has to be borne in mind in all cases of HIV patients who present with suspected CAP. So these are the risk factors for PCP pneumonia in patients without HIV infection. HIV infection itself is a risk factor for PCP pneumonia, but those patients who are not having HIV infection, these questions have to be addressed. Whether the patient is on glucose corticoid use, or is the patient on immunosuppressive drugs such as TNF alpha inhibitors, anti-rejection medications, purine and analogs, whether the patient is having some defects in cell-mediated immunity, cancer, hematologic malignancy, solid organ transplantation, whether he's on treatment for rejection, or has got some severe malnutrition, malnutrition, primary immunodeficiencies, prematurity. All these things will have to be asked in history itself if you are suspecting a PCP pneumonia. So moving on to the clinical features. Usually in HIV patients, patient will have fever, dry cough, and fulminant respiratory failure. Whereas in normal patients, PCP, patients will have a very indolent and a less severe dyspnea and cough. And nearly all patients with PCP will have either hypoxemia at rest or with exertion, or an increase in the alveolar arterial oxygen tension gradient. So this is a chest radiograph of a pneumocystis jirovecii pneumonia with ground glass opacification. And in lab investigations, you'll see elevated LDH, which is suggestive of a PCP pneumonia, provided you have excluded all the hematological malignancies. But this is not very confirmatory. Another test which can be sent is serum beta D glucan assay, which is a PCP cell wall component. It can be elevated in a PCP pneumonia. But the definitive diagnosis is usually based on a tinctorial staining, fluorescent antibody staining, or a PCR based assays of respiratory specimens. Usually BAL. After intubation, you can get the sample and do these tests. X-rays usually shows a diffuse bilateral interstitial infiltrates, and unusually you can get lobar infiltrates, pneumatococcus pneumothorax. So any patient, immunocompromised patient with pneumothorax, always suspect a PCP. So these are the drugs which are used in the treatment of a PCP pneumonia in adults and adolescents. The preferred regimen is trimethoprim sulfamethoxazole, 15 to 20 milligram per kg per day of the trimethoprim component orally or IV, given in 3 or 4 divided doses. This is usually given. This is given IV if the PaO2 is less than 60 millimeters of mercury, or if the respiratory rate is more than 25, or if there is any respiratory fatigue. So if there is any respiratory issue, it should be given IV. Otherwise, you can give it even orally. So these are the alternative regimens that are used. If severe disease, you can even add pentamidine. And a word regarding adjunctive glucocorticoids, prednisone. If the room air saturation PaO2 is less than 70 millimeters of mercury, A-A oxygen gradient is 35 millimeter mercury or more, or if the SpO2 is less than 92%, you will have to add adjunctive glucocorticoids, prednisolone 40 milligram orally twice daily for 5 days, followed by 40 milligram orally OD for 5 days, and then 20 milligram OD for 11 days. So all these things, the treatment of PCP pneumonia usually happens inside the ICU and not really in the emergency department, unless you are keeping the patient for days together. This is an X-ray of a CMV pneumonia, which shows multifocal patchy pneumonia. So moving on to the next important component of pneumonia, that is aspiration pneumonia. Aspiration pneumonia refers to adverse pulmonary consequences due to entry of gastric or oropharyngeal fluids which may contain bacteria or exogenous substances into the lower airways. That's called aspiration pneumonia. So these are the conditions that predispose to aspiration. If the patient is having altered consciousness, the patient is under the influence of alcohol, had a seizure, head trauma, had some drug overdose, or if the patient has got some dysphagia, some esophageal disorders including stricture, tracheoesophageal fistula, oropharyngeal obstruction, or if the patient has already had some neurologic disorder, multiple sclerosis, myasthenia gravis, amyotrophic lateral sclerosis, stroke, or if there is a mechanical disruption of the usual defense barriers such as NG tube, endotracheal intubation, tracheostomy, bronchoscopy is done, or if there is protracted vomiting, gastric outlet obstruction, all these things will predispose to aspiration. So broadly speaking, aspiration pneumonia can be classified into chemical pneumonitis, bacterial aspiration pneumonia, and mechanical obstruction. So chemical pneumonitis refers to the aspiration of substances, for example, acidic gastric fluid, that usually cause an inflammatory reaction in the lower airways, and that is independent of bacterial infection. That's called chemical pneumonitis. That is independent of bacterial infection. It just causes an inflammatory reaction in the lower airways because of that acidic pH of the gastric fluid. Whereas in bacterial aspiration pneumonia, it refers to an active infection which is caused by inoculation of large amounts of bacteria into the lung via the orogastric contents. And these bacteria can be aerobic, anaerobic, or even a mixture. And mechanical obstruction refers to aspiration of fluid or particulate matter that obstructs the airway or triggers reflex airway closure, but without an associated parenchymal inflammatory reaction. So this is the major point. There will not be any associated parenchymal inflammatory reaction in case of mechanical obstruction. So aspiration pneumonitis, there is another classification which is caused by lung injury by gastric acid. Aspiration pneumonia is a pneumonia by bacteria. This is an alternate classification which is given. So moving on to the mechanism of chemical pneumonitis. Chemical injury following gastric acid aspiration. That is the pathology behind chemical pneumonitis. So acid pneumonitis evolved rapidly following aspiration of around 70 ml acid with pH of less than 2.5. Okay, and once it is aspirated, 70 ml of this thing is aspirated, within 3 minutes there is atelectasis, peribronchial hemorrhage, pulmonary edema, and degeneration of the bronchial epithelial cells. And by around 4 hours, the alveolar spaces are filled with polymorphonuclear leukocytes and fibrin. And at the end of 48 hours, you can see hyaline membranes. And at this time, at the end of 48 hours, the lung is grossly edematous and hemorrhagic with alveolar consolidation. So this is how chemical pneumonitis happens, especially acid pneumonitis. So the clinical features of chemical pneumonitis, it will be usually patient may have abrupt onset of symptoms such as dyspnea, cough, hypoxemia, tachycardia, and usually fever is of very low grade. And on auscultation, you may get diffuse crackles or wheezes, and opacities in the chest X-ray usually involves the dependent pulmonary segments. That's about chemical pneumonitis. And the diagnosis is presumptive based on clinical features and course. And usually bronchoscopy is not necessary because it just demonstrates some erythema, some inflammation of the bronchi, and which indicates some acid injury, nothing else. And the chest X-ray abnormalities typically appear within 2 hours. Treatment is supportive, give suction, empiric antibiotics for patients who have persistent or progressive respiratory impairment with systemic signs of inflammation. Steroids are discouraged. So moving on to the bacterial aspiration pneumonia. The microbiology includes oral anaerobes such as Peptostreptococcus, which are gram-positive cocaine chains, Fusobacterium nucleatum, Fusobacterium necrophorum, Pruvotella, Bacteroids species. And also you can have traditional HAP and HCAP organisms such as Staph aureus, Pseudomonas aeruginosa, and other gram aerobic or facultative GNB. So both these things can happen. These organisms may be responsible for a bacterial aspiration pneumonia. So if the aspiration pneumonia involves anaerobes, it usually evolves over a period of several days or weeks. And it has got a more indolent onset of symptoms and fever with absence of rigors. But if the bacterial aspiration pneumonia is secondary to Staph aureus or GNB, which is otherwise called hospital-associated aspiration pneumonia, it has got a very faster tempo when compared to anaerobes. And of course, predisposing condition for aspiration will be present, as I've already mentioned. And at times, patient may have the concurrent evidence of periodontal disease. And if you examine the sputum, it has often got a very putrid odor. And this putrid odor is characteristic of anaerobic infection. If you do the gram stain, that will show the characteristic morphologic features of anaerobes. And chest X-ray shows involvement of the dependent portions of the lung or segments. And the evidence of pulmonary necrosis with lung abscess or empyema is consistent with an aspiration pneumonia. So the investigations, chest X-ray may be negative early in the course, but CT will identify. And you usually send blood cultures, sputum gram stain and culture. Also the urine streptococcal antigen test, sputum or urine Legionella testing, respiratory virus panel. So basic thing you'll have to understand is there are two types of aspiration pneumonia. Community acquired aspiration pneumonia and hospital acquired or healthcare associated aspiration pneumonia. So if you the antibiotic selection for community acquired aspiration pneumonia, you can just go through this diagram which has been taken from UpToDate. So here your target or organism, apart from the routine strep pneumonia, the cap pathogens are the anaerobes. So you'll have to give an additional anaerobic coverage. So these questions will have to be answered. Whether the patient is the clinical picture of the patient strongly suggestive of aspiration pneumonia based on witnessed aspiration event, imaging showing opacities in the dependent areas of the lung, strong risk factors for aspiration such as swallowing difficulties, recent surgery, altered consciousness, signs of pneumonia including fever, shortness of breath, purulent sputum, or hypoxemia. If this clinical picture it's not suggestive of aspiration pneumonia, then you will have to treat it as community-acquired pneumonia, as I've already mentioned elsewhere. But if any of these points are there, then you'll have to consider admission to the then you'll have to take it as community-acquired aspiration pneumonia. So the next question is whether to treat the aspiration pneumonia in the hospital or in the OP setting. If you're planning to uh, treat it in an OP basis based on the clinical parameters and lab parameters and all, then the treatment of choice will be amoxicillin, clavulanic acid, and alternative choices are moxifloxacin or clindamycin. But if you're planning to admit the case in the hospital, then decide whether the patient requires ICU care or not. If the patient is severely ill and requires ICU care, then as always you'll have to obtain blood cultures and sputum gram stain culture and all, and on top of that you'll have to start empiric therapy with piperazolone tazobactam or imipenem or meropenem. If the patient doesn't need ICU level of care, that is, if the patient is not that severely ill, then apart from doing the blood cultures and sputum gram stain and culture, you'll have to start empiric antibiotic therapy with ampicillin sulbactam. The other alternative choices include ceftriaxone, cefotaxime, plus metronidazole for anaerobic coverage. Okay, but anyway, for the IDSA, according to the IDSA guidelines, they suggest anaerobic coverage only if lung abscess or empyema is present. So moving on to the hospital-acquired or healthcare-associated aspiration pneumonia. Here in this case, the aerobic bacteria is much more important than the anaerobes. Aerobic bacteria including especially gram-negative bacteria and Staph aureus. And in such cases, you will have to follow the guidelines for the hospital-acquired pneumonia, which I've already mentioned. And if there is suspicion for anaerobes, you'll have to add a treatment, add anaerobic coverage also. And when there is a perceived need to treat anaerobic bacteria as well as resistant aerobic gram-negative bacilli, carbapenems are preferred more than piperazolone tazobactam. And you also require an agent against which has got activity against MRSA. And if the patient has got associated pleural effusion, you'll have to do a thoracocentesis to exclude empyema. If the patient is allergic to penicillin, you can go ahead with moxifloxacin or clindamycin. So moving on to the next aspect of aspiration pneumonia, that is called mechanical obstruction. So aspiration pneumonia may involve fluid or particulate matter that are aspirated and are not inherently toxic to the lungs, but can cause airway obstruction and reflex airway closure. Okay, and these matter include saline aspiration, barium aspiration, water aspiration, or if the patient has aspirated gastric contents with pH less than 2.5. All these things can cause airway obstruction and reflex airway closure, and that is called mechanical obstruction. That also comes under the aspiration pneumonia. So the treatment is basically supportive treatment, lateral head positioning and oropharyngeal suctioning, tracheal suctioning. And during feeding time, you'll have to keep the patient in the semi-upright or upright positioning. This is all about mechanical obstruction. Another important entity is lipoid pneumonia, especially if patients aspirate mineral oil, industrial oil, white petroleum, which is usually used as just for constipation or as a vehicle for decongestants or for nasal application of white petroleum. So if you look at the chest X-ray, you may get bilateral lower lung zone opacities, but it's not diagnostic of lipoid pneumonia. You may have to do a CT, which may show areas of consolidation containing foci of fat attenuation. But this is, X-ray is not that confirmatory. CT is confirmatory. Also, you can do a bronchoalveolar lavage, which may reveal lipid-laden macrophages with large vacuoles that stain positive with oil red O stain, which is non-specific. Okay, and treatment is basically supportive cessation of exposure to the oil source. So these diagnoses are usually made in the ICU or in the ward setting, and not in the emergency setting. In the emergency setting, usually we treat all these cases as community acquired pneumonia or like aspiration pneumonia. So moving on to the complications of pneumonia. One is lung abscess, especially with pneumococcus and Klebsiella. Then comes empyema, pleural effusion, meningitis, bullous meningitis, carditis, suppurative arthritis, necrotizing pneumonia associated with community acquired MRSA, sepsis with septic shock, ARDS, MODS, and death. So all these complications, like it can vary with the type of organism that is responsible for pneumonia. You can just go through the initial slides which I've already covered and see which bacteria or a typical organism is causing each uh, complication. So what precautions to be taken to prevent pneumonia? Basically, smoking cessation when appropriate, influenza vaccination for all patients, pneumococcal vaccination for at-risk patients. So basically vaccination and smoking cessation. So that's all about pneumonia. For exam purpose, most of the time I've seen questions being framed on community acquired pneumonia, especially essay questions. And aspiration pneumonia, hospital acquired pneumonia, all these things I've seen short notes. And also I've seen some questions on the various scoring systems, especially the CURB 65 scoring system. And that's all about pneumonia. It's indeed a very vast topic, and you need more focus and attention on the various slides which I've already enumerated in the presentation. And as of now, I think this is the most up-to-date uh, guideline on management of community-acquired pneumonia. Thank you.